Welcome to the Empowering Neurologist. I'm Dr. David Perlmutter. Today on the program, I'm going to have the great pleasure of interviewing Dr. Anna Cabeca. I've known Dr. Cabeca for many years. She is board certified in OBGYN, obstetrics and gynecology, but she's also board certified in anti-aging and regenerative medicine. She did her residency in OBGYN at Emory University in Atlanta, Georgia. Dr. Cabeca frequently lectures both nationally and internationally in the areas of restorative health and also women's health issues. She is a trainer and instructor for other physicians as it relates to how they utilize what is called bioidentical hormone therapy, and we will be talking about that as well. Dr. Cabeca is the mother of 5 children. She's fluent in 4 languages, and she has traveled around the world learning various healing modalities from leading physicians, scientists, and researchers in Asia, Europe, the Middle East, Africa, South America. She is the co-creator of the Sexy Younger You Telesummit that you may have seen on the internet, and the creator of the highly acclaimed virtual transformational programs Women's Restorative Health and Sexual CPR, as well as Magic Menopause. And we're going to give you later on the links to these online programs. So let's just jump into our interview. Well, welcome, Dr. Cabeca. I'm really excited to talk to you today.
It's exciting to be here with you as always, Dr. Perlmutter. Thank you for having me.
And I want to just jump right in because, as I mentioned in the intro, there is sure a lot of confusion about menopause, perimenopause, premenopause, what women should be doing, what's actually going on. And can you just give us a brief overview in terms of maybe the standard of care, the standard practice, and how generally medicine looks at menopause and what is going on in terms of treatment?
Yeah, absolutely. So wanting just to kind of give people a background on the hormonal changes that are occurring throughout our life. We all know that we have cyclic menstrual hormonal changes that occur on a monthly basis. And as we get older, our ovarian reserve decreases and there starts to become an imbalance in our reproductive hormones and we call them our mother hormones. So progesterone levels in our mid-30s start to decline more rapidly at that point than estrogen or testosterone or DHEA, other neurosteroids or other endocrine hormones that are really key to our balance, our peace of mind, our menstrual regularity, our fertility, all of those things. So typically what happens is as these hormone levels start to shift, with progesterone starting to decline around our mid-30s, estrogen mid-40s with fluctuating levels, highs and lows, and testosterone and DHEA, a slow general decline, we start to get these symptoms of estrogen dominance. So I can go through what that looks like from a patient coming into a gynecologic office or their primary care physician, if you'd like.
Sure. So, I just want to just kind of as an observation, you mentioned progesterone, and I think there was sort of a teaching, correct me if I'm wrong, amongst those dealing with working with menopausal women that, well, progesterone is just pro meaning for, gest meaning gestation, so it's really not an important player as it relates to what your needs are now that you're reaching menopause. So, what happened with that, and has that been sort of overturned?
Well, it's in the process of being overturned because we know that, like I mentioned, these are neurosteroids as well. Progesterone has such a big function in our brain health, memory. It has a big function for our bone health, our breast health. And the problem has been the interchanging misuse of the word progesterone with synthetic progestins that are negative, that have negative cardiovascular profiles, negative breast profiles, and the list goes on. But also, it's absolutely true. There's this general misunderstanding that when we are menopausal and we don't have a uterus, that you no longer need progesterone to protect the uterus from endometrial cancer or protect you from endometrial cancer because you don't have a uterus, so you're not going to get endometrial cancer. Well, then there goes an even further rapid decline into brain health, bone health, breast health. So with or without uterus,
you have already touched upon something I think that's very important, and that is this is well beyond breast health and uterine health if a woman still has her uterus. and maybe bone health. I think women have kind of bought into the notion that hormones play a role in whether or not they're going to get osteoporosis. But you even mentioned brain health, and I think that's a wonderful segue into these cognitive changes that women seem to experience perimenopausal and postmenopausal. What's going on with that?
Yeah, absolutely. And this is kind of, where I joke, this is where gynecology meets neurology, right?
Right here on Skype. Who knew?
Right here. So we know that progesterone is neuroprotective in our brain. And what's interesting in the perimenopause, menopause, what we notice are diminished memory, mood changes, and it's a function partly in decline of these mother hormones, progesterone, and add in there also pregnenolone, but specifically progesterone. So where we're seeing, women's memories are better than men pre-menopause, and according to a recent study, worse than men post-menopause. And I think progesterone for sure has a role in this. And as we add back progesterone, as I've done in tens of thousands of clients, what they will say, which is so beautiful, is that, I feel like the fog has lifted.
Nice.
I have memory back. I have clarity back, peace.
So, we all grew up in the time of Premarin, extracted from pregnant mare's urine, hence the name Premarin. And there then came the time that, maybe there was this concession in terms of mainstream gynecology that, well, maybe there is something in the realm of progesterone that women need. And we saw things like Prempro, which you mentioned was, in fact, a progestin, not natural progesterone. But, clearly it's a much bigger issue than just estrogen and progesterone, isn't it?
Yeah, it's a much bigger issue. And you're absolutely right. When we started with the magic, the magic purple pill, the magic estrogen pill that we were promoting 50, 60, 70 years ago, women started to get estrogen-only hormone therapy as a help to the perimenopause, hot flashes, etc. And then the increasing incidence of endometrial cancer was identified as this unopposed estrogen. And so here was synthetically then created a progestin type compound, or a progesterone type compound, but a progestin, to marry the two so that you wouldn't have the risk of the endometrial cancer technically if you were on this combination. So that's where the philosophy evolved. Well, if you don't have a uterus, you don't need the progestin component.
Well, it seems unusual. I think it will appear unusual for our viewers that there's really a move these days to consider bioidentical replacement therapy for women, actually giving them what we used to consider to be a male hormone, testosterone. So why would women need testosterone?
And testosterone and DHEA, both androgenic hormones that have similar functions. So one of the key thing is that as we get older, our testosterone levels decline, as well as DHEA, another very important androgen that I care about replacing for women as well as men. And this affects also bone integrity, memory, muscle mass, and cognitive ability, and the list goes on from there. And it's really important, especially for women, in also vulvovaginal atrophy, vaginal dryness, incontinence issues can all be helped with replacement of these hormones and maintaining the healthy skin and tissue there. But in general, what we see is, especially in stages of stress, we're going to have lower levels of DHEA and lower levels of testosterone as well as estrogen, or reproductive hormones, right? We're not going to be in that breeding mode, right, when we're way stressed. In fact, that leads us to a disconnect, a high cortisol, low oxytocin, low testosterone, low DHEA kind of unhealthy phenomenon for the long term. It's essential in the short term, but not in the long term. And so we get more inflammatory conditions, bone loss, and that's debilitating for women in the menopause, postmenopause, hip fractures, etc., that I see incredibly devastating.
So, your approach has always been, and you've lectured about this idea about personalizing the approach per patient, as opposed to, we're just going to develop a medication and then force it upon women in general. So how do you then go about assessing each individual woman in terms of what her needs may be for replacement and other lifestyle changes?
That's a great question. And this is where the art of medicine comes into play, right? And the role as a physician who is designed to be a teacher, right? An educator, a teacher, a guide for that individual to acknowledge their responsibility and their power in achieving a healthy body, mind, and spirit, and putting that together. So hence the interplay of the art of medicine. And I've worked on developing this over time and through the educational programs that I've designed, because each person will take an aspect of it at their time in their life. But the key thing that I recognized over my medical practice of treating clients was on intake. There's 90% of our diagnosis as physicians is based on our history and physical examination. And with that said, 90% of the cure is in the lifestyle recommendations and modifications that client then takes. So that those first encounters are really important. So I believe in assessments, questionnaires, and also initial introductory lab tests and some key lab markers that will help us look at inflammatory, we'll look at endocrine, we'll look at blood sugar metabolism, some comprehensive testing, but then putting them on a keto alkaline diet program. So that is based on low allergen potential. So very much the brain philosophy in lifestyle, in achieving a very low carbohydrate load, but enough for us women so we don't go keto crazy with an imbalance with too low carbs, and keeping an alkalinizing diet, which is very key, as well as the lifestyle that goes with that, intermittent fasting, time between meals. So I put them on a modified elimination diet based on these principles. And that's part of a detox program that brings them back into a low inflammatory state, which so helps our neurotransmitters and our hormones, our reproductive hormones, get a boost and get in balance. And then from there, based on lab tests and the client, right? We treat the patient, not the labs, but the labs can help guide us, is customizing a routine. And that's where custom and compounding hormones can be very valuable in fine-tuning an individual's care.
So we've heard that term reproductive hormones, but it seems to me that that kind of narrows us in terms of our appreciation with respect to how widespread throughout the body the effects of these hormones really are.
True, exactly.
And when you are assessing hormones, is that blood work, urine work, saliva? What do you find is best?
Well, I always tell a client that every body fluid, when you come into my office, every body fluid at some point or another will be examined. So heads up on that one.
Yeah, spinal tap? You didn't say that one, thank goodness.
No, I'll defer the spinal tap, but okay, almost every fluid.
And do you then follow those laboratory studies over time along with assessment of the patient to determine if it's working?
That's the ideal. Typically, I evolved from doing a lot of urinary hormone studies, salivary hormone studies, blood, serum hormone studies, and I've really designed it so I look more now at blood, but with a very comprehensive questionnaire and kind of approach over time. But I'll typically look at blood levels, and some key markers that I'm looking at are certainly the total estrogens, estradiol, progesterone, free and total testosterone with LCMS technology, which is the way we're analyzing the blood work is as important as the type of collection we're getting. So DHEAS, and then your complete thyroid panels and inflammatory markers.
And you had mentioned that urinary issues, incontinence in women, perimenopausal, postmenopausal, is very common. Obviously it is. Maybe our viewers would be surprised to learn that there are some hormonal implications in terms of why that's happening. What's the mechanism there? What is happening?
Well, there are several things. So definitely there's also the microbiome, right? The healthy vaginal atmosphere, milieu, and bacteria will start to decline. Glandular secretions start to decline as we age. So we're going to get a shift in the vaginal flora, a shift in the hormonal integrity of the tissue in general, from muscle strength, from the connective tissue, the decreasing collagen, all of that can occur because of declining levels of estrogen, testosterone, DHEA, progesterone. So our androgens and our estrogens both have a significant role. And then as a gynecologist performing many incontinence surgeries, something that involved in my practice was using vaginal hormones prior to surgery. Well, when I started using vaginal prescription testosterone and DHEA, I started needing to perform less surgeries. I mean, it was like that ethical battle. Well, I did this pre-op and now you don't have symptoms. I can't obviously operate anymore. So I learned that there was so much that we could do to repair the health of the vagina for incontinence, prolapse, vaginal dryness, orgasm, sexual health issues, that really comes from restoring a healthy tissue, a healthy connective tissue mucosa. What's the problem is, David, in this arena of gynecologic health is that when women complain of vaginal dryness, they're given vaginal estrogen. Now, estrogen will work on the mucosa, the first layer of the vagina, but androgens work all the way down to the muscle layer. So hence will bring back strength to the muscle, just like testosterone builds up a muscle in an arm, and it will also build up the muscle of the urethra and the vagina, and the same with DHEA in more recent studies. And so it's been really a passion of mine to make this, actually I use DHEA vulvar cream to make that accessible to clients, to start helping preventatively from the just natural decline of the hormones as we age that really affects our lives. Because if we're having incontinence when we're going out to run, we're not going to run. Right. If we're having a vaginal discharge every time after we have sex, or we're having pain every time we have sex, we're not going to want to have sex. So repairing this, it's so huge. And I'm really passionate about doctors learning to prescribe vaginal hormones and then getting this vulvar cream out to clients as well. So a big part of it.
And let's go back to hot flashes for just a moment. What is the mechanism? Why do women get hot flashes? And then as we understand that, what can you then do therapeutically?
Okay, so why women get hot flashes? There are many triggers for hot flashes, but one of the main reasons is a dropping threshold of our thermoregulatory response. Our temperature threshold declines. Estrogen, our declining levels of estrogen and the androgens play into this. So also with that, we know there are certain triggers that are going to make us more susceptible to hot flashes, and why some of us have worsening experience over time. One is the very low levels of estrogens and androgens. So we want to raise that threshold so that we have less hot flashes and avoid the triggers such as caffeine, such as stress, such as crowded hot rooms, and lack of, high spiking cortisol is part of that.
I think you said, and a bunch of teenagers at home. How does,
yeah.
in one of your questions, you talked about having a bunch of teenagers at home, which probably corresponds to about the time when these events are going to occur.
Well, I say God has a really twisted sense of humor to make us go through the perimenopause, menopause transition and have our teenagers going through puberty at the same time. It is just not a just
But do you believe that these issues with menopause are more in line, or are seen more in Western cosmopolitan cultures? I mean, I can't imagine this would be a good survival mechanism for us. So it would seem that this is something more related to our other lifestyle choices, mostly dietary.
Absolutely. Dietary plays a big part
and
in that.
That might be mediated through then the effects of the microbiome in terms of hormone metabolism.
Especially because a lot of our hormones through the gut GI tract metabolism we're going to look at those metabolites, which can either be healthy and optimal or very dangerous and destructive and pro-inflammatory. So we want to look.
I want to move on to, you have a couple of really, several actually, very powerful online programs. Can you tell us about those?
Yes, absolutely. So I have Magic Menopause, which has been my program that I've just been driving women through that are in the premenopause, perimenopause, and postmenopause timeframe for hormone balance. And that really emphasizes the keto alkaline program.
You're going to tell us all about that, but what is the website so people can get more information?
Magicmenopause.com.
Magicmenopause.com. Probably on the bottom of the screen right now. And again, tell us what that does.
So that will take clients through a lifestyle management of the menopausal symptoms and really to educate through my head to toe approach what we can as women empower our bodies with to regain balance, to lose the hot flashes, mood swings, keep the monster within us at bay, right? Totally kick her out or the nasty witch off your shoulder and really regain that mental clarity, that relational juice, right? Rebuild our oxytocin hormone in this, as well as managing those sex hormones that we talk about.
And there's another program that you have.
Sexual CPR is another program because, again,
That's
we can
a great
get
name, sexualcpr.com, right?
Sexualcpr.com.
And that
yes.
may be appearing on the bottom of the screen right now as we speak as well. And what does that program do?
So that is really about reigniting the relationships, and that's from the hormonal perspective. And as we deal with things with vaginal health and oxytocin cortisol connection, I go through that in a very holistic way in reigniting the relationship, also the physical body, and addressing the many things that can affect our feeling sexy and our sex drive. We know the answer is not in a prescription drug. So
that's a very important point, because I think we are pretty well led to believe that the answer to every one of our ills is something that you pick up at the pharmacy, whether it's a standard pharmacy or even, as you're talking about, a compounding pharmacy, making it specific. But I think what you're getting at is this is a much more comprehensive approach to, it's really, as you described it, a functional medicine approach. Can you tell us what that means, functional medicine?
Yeah, absolutely. It's getting to the underlying causes of the problem. So from what I've recognized time and time again and looking at the symptoms and the syndromes that clients come in with, as we address these underlying issues and really healing the cell membrane, healing the microbiome, that just creates a resolution in so many of these diagnoses.
Great. And then last but not least, people who want to learn more about you, what can they do?
Well, they can come to my website, and we actually have a gift page for your audience. So at dranacabeca.com/Dr. Perlmutter. And
wow, I knew nothing of this.
Yes, especially for your audience. So
nice, very kind of you. Well, great. This is really very good information, and I appreciate you taking the time today. And again, for our viewers, we will have all of these websites available to you. And Dr. Cabeca, thanks for joining us today.
Thank you for having me, Dr. Perlmutter.
Okay, bye for now. Well, thank you to Dr. Cabeca for sharing such great information. And, it's really quite clear that in the area of hormone replacement therapy, especially, there is a lot of conjecture out there. We don't know from one day to the next, what women think that they need to be doing. We all remember the days of women taking various types of hormone replacement therapy and then seeing studies that were published showing that there were in fact significant risks with certain types of therapeutic interventions. So again, you've seen on the program some interesting information and links to follow Dr. Cabeca. Hope you enjoyed the show. I'm Dr. David Perlmutter. Thanks for joining us.